May I invite Dr. Shafeek Shamsudheen now.
Good morning, all. First of all, I'd like to thank the organizers and ASI Kerala chapter for giving me this privilege of delivering a talk after my teacher and mentor, Dr. Sulfikar, and in front of all my teachers, both on the stage as well as in the audience. So thank you for that. My mandate today is to talk on conquering PIRADS 3 and 4 non-palpable breast lumps. I bring greetings from MVR Cancer Center, Kozhikode. So PIRADS, we all know, was a system introduced by the American College of Radiology in 1993 with three main intentions. Number one was to standardize the reporting of breast imaging. Number two, to provide a clear communication to the clinicians regarding what the radiologist has seen. And number three, and lastly, often ignored but very, very important, is to audit your results, to get the final histopathology and see what is happening to your PIRADS 3 and 4 lesions. Now, this is a general structure of a standard reporting. Starts with the indication, the breast density, important findings following standard descriptors. The fourth point is very, very important, comparison to previous studies. It's a very, very valuable clue, followed by the final assessment category with the management recommendation. And lastly, to communicate unsuspected findings to the referring clinician. As much as 20 to 30% of non-palpable lesions can turn out to be cancer. So these are the standard descriptors which we all know. I will be focusing on PIRADS 3 and PIRADS 4. Let's start with PIRADS 3. So PIRADS 3 is a lesion which is used to be called probably benign, which has got a less than 2% chance of harboring malignancy. Generally, these lesions are not expected to change, but you would like to establish stability, hence the follow-up. So the lesions mammographically which are characterized as probably benign are three. Number one, a non-calcified circumscribed mass. Number two, a focal asymmetry. Number three, a solitary group of punctate calcifications. Now, the basis for this classification and the malignancy risk that we just told of less than 2% came from these two large studies by Sickles and Varas in 1990. The premise proposed by underlying this concept was that using defined criteria, you could easily classify these lesions which have a low likelihood of malignancy, where surveillance demonstrates a change either downgrading to PIRADS 2 or upgrading to PIRADS 4. And in case you miss a cancer in that less than 2%, they would be diagnosed later at an early stage so that there is no survival detriment to the patient. So these are the underlying premises of PIRADS 3. Now, what did they find? Sickles, as is shown in the study, there were 17 cancers after 4-year follow-up of these lesions, and most of them were stage 0 or 1. And Varas also found a higher incidence, 22% of DCIS. Now, at that time, this has changed now. The proposal was just 1 year after the first edition of PIRADS, the lesions satisfying this criteria mammographically should be kept on periodic surveillance irrespective of lesion size and age. Now, this is what I mentioned earlier, the chance of malignancy less than 2%. Now, few important points I will be touching on for lack of time. Number one, you do not use PIRADS 3 after a screening mammogram. It has to be after a full diagnostic workup in the form of additional views, ultrasound, tomosynthesis, and physical examination. This is applicable to mammogram. So, screening mammogram, you don't say PIRADS 3. Now, why is this required? Why is additional evaluation required before calling it PIRADS 3? There are two main reasons. Number one, you want to eliminate lesions with which additional evaluation like ultrasound, which may show a mass to be a simple cyst, which can be easily classified as benign and downgraded to PIRADS 2 and avoid unnecessary follow-up. On the other extreme, you have lesions, identify lesions which may look like fibroadenomas like your triple negative breast cancers, medullary cancers, which may require immediate biopsy. Now, there are studies which have shown that if you miss these cancers, then these are aggressive lesions and they come back at a very later advanced stage with a survival detriment. Now, these are few examples. You can see there is a circumscribed mass with some calcifications inside the lesion that was followed up on 6 months and 12 months and later downgraded to PIRADS 2. Now, this is an area which started off as a calcification, group classification. Now, you can see after 1 year it has increased. So, this has been upgraded to PIRADS 4. Now here you can see the third description, that is a focal asymmetry. When you compare both breasts on craniocaudal and mediolateral, you can see there is an obvious asymmetry here, and on a spot magnification you can see that that's definitely looking suspicious, which prompts a biopsy, and this turned out to be malignancy. Now, similar to mammographic findings that I described earlier, ultrasound findings have also been proposed by Tom Stavros from US. Now, this is a typical appearance of a fibroadenoma in a 40-year-old woman. You can see that it is a parallel orientation, and there is an oval shape with well circumscribed margins. Now, to avoid confusion in BIRADS 3, what are the do's and don'ts? Number one is to follow strictly the algorithm of follow-up. You follow up with a unilateral, ipsilateral same side imaging at 6 months, followed by repeat bilateral imaging at 1 year and 2 years. If it's stable, you make it BIRADS 2. And always use the 3 specific findings on mammography to label it as BIRADS 3. Also look for characteristic ultrasound findings. And even if a patient or clinician asks for a biopsy, do not change it. There is no need to change it to a BIRADS 4 just because you took a biopsy. Don'ts is, don't use BIRADS 3 when the radiologist is unsure of what the lesion is. If you are unsure, make it BIRADS 4. And don't use in a screening examination. And if a lesion is changed in a size or extent by more than 20%, as Ulfi so told, then use category 4. Few questions on BIRADS 3 is short follow-up needed for BIRADS 3. Why can't you, if it's a stable lesion, why can't you go for a longer follow-up? Now, this study, which was published very recently from Wendy Berg's group, it's a large study based on the National Mammography Database, showed that up to 58% of these BIRADS 3 lesions, which later turned malignant, were picked up at and around the 6-month follow-up. So, the first follow-up has to be at 6 months. Second question, does age play a role in better classifying these lesions? Again, Wendy Berg's group, the same database they used, they found that both the cancer yield and the positive predictive value of BIRADS 3 lesions increases with the increasing age. So, that's what is shown here. As age increases, the risk of positive predictive value and the cancer yield increases. Now, what about a BIRADS 3 lesion in a breast which has a biopsy-proven cancer? This is an inappropriate terminology, because 11% of such findings turn out to be malignant and 21% turn out to be malignant if they are in the same quadrant. When to biopsy a BIRADS 3 lesion? When there is clinician or patient concern, when surveillance is not a good option because of various reasons. So this I'll just skip because of lack of time. This is how, these are finer points which tell you when the radiologist is wrong. I'll just skip over this for want of time. Now, these are the few top tips for image interpretation of a BIRADS 3 lesion. Biopsy for more than 20% increase in diameter. Use caution if there is a personal history. Multiple lesions in both breast, BIRADS 2. Developing asymmetry should be called BIRADS 4. Lastly, I'll just finish with these slides. So, BIRADS 4 category, there is no defined guideline to differentiate into 4A, 4B and 4C. There is a wide range of malignancy from 2 to 95%. All of them require, these are the classifications, the lesions which we put into 4A, 4B and 4C, but this is not based on evidence. So, to avoid confusion in BIRADS 4, always you follow the suspicious findings and use biopsy. Two last important questions in BIRADS 4A which may cause a confusion. Suppose you have a BIRADS 4A lesion, as following the recommendation you went ahead with a biopsy and it came as fibroadenoma. What do? Do you have to go for excision just because it is BIRADS 4A, or can you keep on follow-up? There is this classic study which came out in 2017 which looked specifically into this, and they found that you can keep these lesions 3 and 4A which have a fibroadenoma diagnosis on corneal biopsy and no need to excise them surgically. This is applicable only for 4A. And again, just like for BIRADS 3, what is the role of age? Again, age also plays a very important clinical variable. As age increases in all the subcategories, the chance of malignancy also increases. Thank you.
Thank you, Shafeek, for that excellent lecture. Any comments by Murali?
Time issues, sir. We'll proceed to the next.
Any comments from the floor? Any questions?
Excellent presentation, Dr. Shafeek. And there is a take-home message. what should be done in branch 3, how to classify it. And one doubt, there was an addition, there was in one of your slides, it was shown that if it's branch 3, you have got additional investigations.
Yes, sir.
Last one.
Yes. So that actually refers to the spot compression views, the spot magnification views. As I showed in the asymmetry slide, when without magnification it's very difficult. Once you magnify, it becomes very apparent. The speculations at the border can be seen. Sometimes focal asymmetries may hide an underlying mass. So that is one option. The other investigations are ultrasound. You can also go for a tomosynthesis.
Thank you.
One more doubt. What is the difference between 4A, B and C? Actually, what it refers to, A, B, C?
For ABC, as I mentioned, there is no defined criteria. Like I showed in the 3 validated mammographic findings, there has been no such study. So it is introduced in the 2013 edition only for auditing purposes, because the range of malignancy in 4 is wide if you don't subcategorize it. It goes from 2% to 95%. So for auditing, and until further longitudinal studies are available, they have just introduced this. As of now, we don't have any, apart from the subjective findings I showed, there is no evidence to classify it. And it's not mandatory that radiologists should report the subcategory.
It is all a question of percentage.
Yes.
Percentage of malignancy in A, B and C.
Yes.
And what is the definite criteria?
It's not known.
No. Right.
Thank you.
Thank you, sir.